Management of tracheal tumors. Epidemiology. 1. Tracheal tumors are rare, presenting 1.4/million population. 55% are male. Pediatric group are mostly benign, while adults are mostly malignant. The majority of tracheal tumors are secondary endotracheal metastases, occurring via direct invasion from adjacent organs or hematogenous spread. Primary tracheal tumors may be benign or malignant. Benign tumors include capillary hemangioma, chondroblastoma, chondroma, fibrous histiocytoma, glomus tumor, granular cell tumor, hamartoma, hemangiomatous malformation of mediastinum, inflammatory pseudotumor, plasma cell granuloma, leiomyoma, neurogenic tumor, schwannoma, plexiform neurofibroma, peripheral nerve sheath tumor, atypical schwannoma, paraganglioma, pleomorphic adenoma, pyogenic granuloma, squamous papilloma, multiple solitary vascular tumor of borderline malignancy. Malignant tumors include carcinoids, typical, atypical, lymphoma, melanoma, mucoepidermoid carcinoma, non-squamous carcinoma, small cell carcinoma, adenocarcinoma, large cell carcinoma, adenosquamous carcinoma, sarcoma, spindle cell sarcoma, chondrosarcoma, leiomyosarcoma, carcinosarcoma, pseudosarcoma, invasive fibrous tumor, malignant fibrous histiocytoma. Comparison between common tracheal tumors: squamous cell carcinoma vs adenoid cystic carcinoma. Squamous cell carcinoma. Most common. Males more than females, 60 to 70 years old. 90% are smokers. Usually exophytic or ulcerative, and invasive. Aggressive, metastasize early. Usual diagnosis within 4 to 6 months of symptom onset. Adenoid cystic carcinoma. Arise from bronchial glands. Males equal to females, 40 to 50 years old. No smoking association. Exerts mass effect rather than regional invasion, submucosal spread. Slow growth, late recurrences. Usual diagnosis more than 1 year after symptom onset. Clinical presentations. The clinical presentation of tracheal neoplastic obstruction depends on the size of the luminal component, its location and the histologic type and growth pattern. A tracheal diameter 8 mm leads to dyspnea on effort. 5 mm leads to dyspnea at rest. Hoarseness may be present when tumors originate close to or within the subglottic space, but hoarseness does not correlate well with vocal cord palsy or recurrent laryngeal nerve invasion. Dysphagia and diaphragmatic palsy are exceedingly rare. Delayed presentation. Since symptoms are usually mistaken for other respiratory pathology such as asthma, chronic obstructive pulmonary disease or pneumonia. Imaging and investigations. Chest X-ray, CT scan, PET CT scan, bronchoscopy, spirometry, direct laryngoscopy, chest X-ray. The identification of subtle abnormalities in the mediastinal contours or the tracheal air shadow mandates a high index of suspicion for this rare disease. Thus, plain films rarely provide the diagnosis, even though abnormalities may become obvious on later review. 4. Contrast CT scan chest and neck. Routine axial, coronal, and sagittal projections is a precise imaging modality that reliably demonstrates tracheobronchial tumors or extrinsic masses. Positron emission tomography, PET, is helpful in demonstrating the extent of disease for tumors with high radiotracer uptake. Rigid bronchoscopy may be used to core out tracheal tumors, providing tissue for histological diagnosis and aiding in the establishment of a patent airway. Spirometry. Fixed obstruction pattern, inspiratory and expiratory flow loops have a plateau. Variable intrathoracic obstruction pattern, with normal inspiratory loop and an expiratory loop plateau. Management plan. Bronchoscopic debulking, mechanical with rigid bronchoscopy, laser, or cryotherapy. Palliative. Prior surgical resection. Definitive. Particularly if benign with stalk attached to the tracheal wall. Tracheal resection and reconstruction. Provided it's within 1/3 of the length of the trachea in pediatric group or 1/2 the length of the trachea in adult group. Utilization of cardiopulmonary bypass or extracorporeal circulation in supracarinal resections or when carinal reconstruction is needed. Assessment of resectability. The treatment of malignant airway obstruction due to metastasis is mainly palliative and marginal. Tracheal tumors are defined as resectable if the involved tracheal segment can be resected and reconstructed with primary anastomosis. Depending on the patient's age, weight, neck mobility, and comorbidity, approximately half of the trachea may be safely resected. Except in the pediatric group, only 1/3 of the trachea can be resected. Elderly with kyphosis cannot tolerate more than 2 cm resection margin, however, young individuals with a long neck can tolerate more than 6 cm of resection. Contraindications include: major airways or respiratory failure, oral corticosteroids and major comorbidity. Disease-related contraindications include regional invasion of adjacent organs or great vessels, extensive mediastinal lymphadenopathy, distant metastases and previous high dose, greater than 50 GY, irradiation to the trachea. Unresectable tumors, palliative procedures. Endoscopic resection. Using electrocautery, laser, cryotherapy, and brachytherapy provides a palliative option for unresectable tumors or patients with contraindications to surgery with or without the use of silicone stent, stents and T-tube. Self-expandable metal stent should be used if patient survival is expected to be between 3 to 6 months. It's contraindicated for patients with adenoid cystic carcinoma, as they can live more than a year or as bridge to surgery. Expandable stent carries complications such as dislodgement, formation of esophageal and vascular fistulas and stricture formation above and below the stent. T-tube silicone stents should be used in longer-term palliation if survival is expected to be more than 6 months, as they are less damaging to the trachea. Chemoradiation. Palliative radiation may also be offered for the management of airway obstruction symptoms. Because of the rarity of airway tumors, there are no clinical trials that define the optimum approach for unresectable or metastatic squamous cell carcinoma or adenoid cystic carcinoma.